The first keynote speaker of our event is Dr. Tessa Peasgood. She is a health economist and lecturer, a senior lecturer at the University of Sheffield. Many of you coming from the happiness literature might remember one of his most cited publication, Do We Really Know What Makes Us Happy, that she co-authored with Paul Dolan and Matthew White. I don't remember anymore the year, 2008. I don't remember, something about that. So it was one of those initial publication that then become a classic in the literature. Tessa has been progressing in her career to investigate ways to measure and valuing health and well-being outcomes. And I am particularly intrigued by today's talk, Lessons from Healthcare Research, because she will be reflecting on some of the methods, tools, lessons, experience that she gathered in the field of investigating the quality of life in the medical sector, and what we can learn then for measuring progress at large. She will be covering topics that are at the very heart of each one committed to inform the society and decision-making about how to improve quality of life. For instance, the importance of communication with decision-making, engaging with the public and have them into the tool to measure and assess quality of life. Presentation of outcomes on quality of life as a synthetic index and the challenges that this poses. So without further ado, I welcome Tessa. She's gonna speak for about 40-45 minutes, after which we will have time for Q&A before breaking up. So without further ado, Tessa, please welcome us. One thing I would like to ask to you and in general to all the speakers for the coming 2 days, when you'll be presenting, try to move slowly so that the camera can follow you, okay? Because we have also guests that are following us online. So it's nice that they can see the slides, but also see the speaker. And another important thing, questions and speeches, please use the microphone because this ensures that people online can hear us. Tessa, thank you very much for being with us. The floor is yours.
Thank you, Francesca. I might stand over here if that's all right. I'll just see if the camera can move. Maybe I moved too fast. No, it's not going to move. Okay, I'll stand here. Okay, and that's fine. So thank you. And thank you very much for the invite to talk this morning. I'm really delighted to be here and to be in Luxembourg. So when I thought about presenting today, I thought about the things in healthcare research that we do that I'm particularly proud of. And so lessons might be a little bit of an extreme kind of way of framing it. It's really more, what do I think that we do well? And I kind of wanted to share some of those things. And of course, there are things that the wellbeing and happiness researchers do very well too, that we as healthcare researchers could learn from. But I'm really just taking one side of the story today. And it's nice that I can kind of straddle both worlds. As you mentioned, you know, my PhD was very much happiness. But I guess since then, I've really been more of a jobbing health economist. So I'm going to just sort of talk through 6 things that I'm proud of that we do in health economics and outcomes research. And through doing that, I'm also going to weave in a bit of a story about the development of a new instrument that I was involved in at Sheffield. So the first thing that I think we do well is our proximity to policymakers. And that feels a little bit ironic standing up here today saying that. given how close you work with policymakers and, the direct involvement with the Ministry of the Economy. So I think what I'm trying to get at here is our involvement with policymakers at a very micro level. So, as health economists and outcomes researchers, we are very embedded typically in medical research and public health research. And as such, we are quite close to the needs of the decision makers and the budget holders. So really, we, as health economists, we work for the decision makers, either directly or, indirectly, maybe via clinical researchers or via the pharmaceutical industry sometimes. So, we work for health technology appraisal or HTA bodies and agencies that are involved in the reimbursement of interventions. So in the UK, NICE is obviously one of our kind of key bodies that we work to. So the National Institute for Health and Care Excellence. But there are related HTA organizations globally. So we work for the people that commission healthcare. And what we do is really provide them with kind of transparent and systematic evidence that not only tells them maybe what they could be doing, but critically tells them what they could not spend money on. And so really we act to support these more micro level decisions. Should we fund intervention A or intervention B? That's where our kind of health economics evidence is particularly useful. So a long time ago in Sheffield, maybe 2016, which does feel like a long time ago, there was a group of researchers who were very interested in happiness and well-being when we were all health economists. And that included Paul Dolan, who was at Sheffield, John Brazier, who is a sort of long-standing health economist, myself, and a researcher called Clara McCurrier. And we all felt that maybe we weren't doing enough in the area of health economics to bring in life satisfaction and measures of happiness as a way of supporting healthcare decision-making. And so we submitted a large grant to the UK Medical Research Council, which is one of the biggest kind of medical care research funders in the UK. So can we develop something like a wellbeing adjusted life year? Can we put life satisfaction and happiness at the center of decision-making in health? We were very excited by this. And the MRC considered it and said, yes, interesting idea. We are interested, but can I just check something with you? Are the stakeholders interested in this too? Are they interested in actually using such an outcome measure to support healthcare decision-making? Well, we had some buy-in from NICE at the time, so we were kind of like, maybe? Now, they weren't really convinced by that as a response. So we said, okay, well, what we'll do is we'll do some qualitative research to try and directly find out how interested the stakeholders and the decision makers are in a measure that's much more focused on happiness and well-being. And so, we conducted a range of focus groups and interviews with kind of key decision makers across the UK who work in not just clinical health, but public health and also social care. So we also wanted to talk to members of the public. And at the time, NICE was running kind of Citizens Council, which is really public members who are willing to engage in kind of ethical decisions around how we assess interventions in healthcare. So we talked to health and wellbeing boards who are more responsible for social care. So when I say social care, I'm referring to things like support for people with disabilities and for people who are elderly. We spoke to people in Public Health England and NHS England, which is maybe a little bit more clinical, and members of NICE committees, who are the bodies that look at the evidence to decide whether or not an intervention is cost effective and should be funded within the UK's NHS healthcare system. So we tried to both kind of directly and indirectly find out how supportive people would be of the use of happiness and life satisfaction and well-being measures to evaluate health. And we were really pleased that some people were on board with this idea. So, for example, somebody said, well, why would we do anything if it doesn't improve well-being? Which was very much, where we were coming from, that it's the final outcome that we should be interested in. And people said, it's clearly important to look at people as a whole and not just one aspect of how their life is going. Unfortunately, many people didn't support the use of subjective well-being. They felt that really health still had to be the foundations of the outcome that we're interested in if we're evaluating healthcare. And that health, it had some kind of primacy, and people just wanted to focus on, understanding whether people were cured. They weren't so interested in their overall life. And there was a sense in which, health is something that we can all agree on is important. And when it comes to the idea of well-being, so is there really a consensus across the country around what that looks like? And there was a real concern as to whether any kind of well-being instrument would actually result in what the public thinks is a valid and worthwhile use of the public's money. This wasn't what we wanted to hear. Okay. So, we were left really with a bit of a question. It's like, is it our role as health economists to persuade the decision makers that they should be using well-being, or is it our role to support them and provide them with instruments and measurement that aligns to what their needs are? And it will be really interesting to pick this up in the discussion session. I think I have very mixed feelings about this. At times I engage in more persuasive writing that, in fact, we should be considering well-being. But at the same time, as I said earlier, we're jobbing health economists. We do work for the decision makers closely, and that's in many ways one of our strengths. So at this point in the development of the new measure, we really had to go with what the decision makers wanted. And that was the start of the large project to develop this new instrument, which is known as the EQ-HWB, or Health and Wellbeing Instrument. And it's a large international team that was involved in the development, led by John Brazier and Clara McCrea at the University of Sheffield, including teams from Argentina, Australia, China, Germany, and the US, funded by matched funding from the MRC in the UK and the Euroqual Foundation, who are the ones who now own the IP for the instrument. And the aim of what we were trying to do was to develop a new instrument that could be used to assess and evaluate interventions in healthcare, in social care, in public health, and also incorporate the impact on carers' quality of life from those interventions as well. So it's a generic instrument that can be used across a range of sectors. That was our fairly ambitious aim, and to be used anywhere in the world. So yeah, we set ourselves quite a difficult target. So this moves me on to the second thing that I think I'm proud of in healthcare research, and that is how we involve the public as collaborators in the research. So Public and patient involvement, or PPI, is defined by the UK's NIHR, which is the National Institute for Health and Care Research, as being research carried out with or by members of the public rather than to or about or for them. And the NIHR in the UK has been really instrumental in trying to encourage healthcare researchers to involve the public as collaborators in all of their work. And really, this is now expected as bog standard in healthcare research by most funders, certainly in the UK. And it definitely has some real positives. And I think it's something at Sheffield that we have explicitly embraced, that any research should consider carefully how we involve members of the public from a very early stage. And now we try and get seed funding to involve members of the public at the very early planning stages of the work. So prior to getting any money to do the work, because unless we involve them then, sometimes what can happen is that decisions have been made without their input if we wait until we have funding before we involve them. So having members of the public in your research team is really helpful for any research which wants to engage with members of the public, because they're much closer to understanding how our research will be perceived from a public perspective. They're also really good at countering your own blind spots. And often, because we might work, I said, in Sheffield, we often work as a team of health economists. We're all a little bit too similar. We've come from economics and then we've transferred into health economics. And although we may work in interdisciplinary teams, there's a certain sense of kind of communal perspective. And it's really useful to have a completely different voice entering the research team. And the other thing that it can do is really improve the diversity, particularly in terms of the political and social and economic diversity of the research team. It does, however, raise some challenges. It's not always easy. It's not always easy to do in a really meaningful way. What we don't want is public involvement in our research that's a little bit tick boxy, because that's easy to do, but doesn't really get you the advantages of involving the public in the first place. So it's time consuming. It's time consuming of the staff to plan the public involvement, with enough detail to really think through how we can optimize what we can gain from working with members of the public. When we're working in a more generic space in health, it's particularly problematic, because if we are working in a particular condition, so for example, if we were working to develop measurement outcomes in the area of Parkinson's, it would be easy to know who to go and speak to and to try and involve people with lived experience of Parkinson's on our research team. However, when we're working more in a kind of well-being, generic quality of life kind of space, that's a lot harder, because there's no single group of people that we can go to. When we do public involvement, it takes up quite a lot of time in terms of training, and also a requirement that we have to be fairly flexible, because we have to listen to the input from our members of the public, and we don't know what that's going to be. So we have to both put in the time to train and ensure that we are communicating well with our members of the public and remain flexible. And that's particularly difficult if we want full co-production and joint decision-making. So it's difficult to tell a funder exactly what you're going to do if at the same time you want to have co-production with members of the public. So in terms of the EQHWB project, we had an active PPI group that were involved, not from that early stage prior to getting funding, but as soon as the project kind of kicked off, they were involved, and they were involved all the way through. And they were a mix of members of the public, people with health conditions, and carers. But they were only based in the UK, and this project extended across other countries, and the other countries didn't have PPI groups. And also we didn't involve them very successfully in terms of the decision-making stages of the work. And for that, we have got quite heavily criticized in the health space. And as I said, you know, there's an expectation that we do this and we do this well, but it's, I think in Sheffield, you know, we're still learning how that's done. So the third thing I think we do well as health outcomes researchers is really use the public to determine what matters. And if we look at the current regulations for PROMs, or patient-reported outcome measures, there's very much an expectation that the content of any instrument is driven by the voice of the patients. So we find out how their health condition, how their treatment, how any intervention impacts on their quality of life. And that's done through in-depth qualitative work. So it's not kind of superficially, what do you think matters? It's, you know, hour-long interviews where we get behind what people are saying to really understand the way in which they think their health condition influences their quality of life. And this is, you know, it's really standard in PROM's work, and to the point where, you know, in the US, it's kind of central to FDA requirements that this is done. And I think it makes sense that if we are looking at what matters, that it comes from the voice of the public rather than kind of philosopher kings or clinician gods. It's easier to justify. Now, it may not be that comfortable to hand over to members of the public, because we may have to sacrifice some of our theory. You know, our theory of what it is that makes life go well may not be the same as what the public thinks is important. But, you know, this I think comes back to my first point. It's that tension of kind of, do we just, are we just passive in terms of receiving what the public or decision makers want? Or are we kind of proactive in saying they ought to want something different? So in the EQHWB work, we relied on the common approaches within medical care research, which is to rely on the patients and rely on the public and what they say matters. So the first step for our instrument of determining, you know, what's going to be included, what will be measured, what are the domains, relied on a large literature review of the qualitative work with adults across a broad range of different health conditions, social care users and carers. And it's looking at interview level data, qualitative research that's been kind of conducted and analyzed by qualitative researchers to understand the impact of conditions, treatments, social care use, and the role of being a carer on people's lives. And that's where we kind of took the content for the measure. That gave us 32 sub-themes, so a lot of different things. And this is just what's common across conditions, which we've grouped into kind of 7 higher level themes. And if you look at these, are just sort of, you know, fairly high level titles for the themes, but as kind of wellbeing researchers, I think there's probably a lot there that maybe you're not that surprised by. You know, we know the importance of things like relationships and, you know, autonomy, self-worth. These are not things that are in any way surprising. It might be worth just flagging at the top there, hope and hopelessness. And I know when Carol Graham spoke at this session a couple of years ago, she emphasized the importance of hope as a key aspect of well-being. So when we look at what's common in terms of what patients and carers say matters to them in their life in relation to their caring role and their healthcare, it looks quite like a broad measure of well-being. So the next thing that I think we do well as health economists and outcomes researchers is we set quite high expectations in terms of psychometric data analysis and qualitative analysis as well, both in terms of the development of instruments and also in the testing of the validity of those instruments. So there's an expectation that a range of sort of classical psychometric tests will be done at both stages, development and testing. I haven't listed them all here, but things like good hypothesis testing around known group validity, ensuring that instruments are reliable in terms of retest over time, ensuring that our instruments are responsive to change. And of course, that's very important in the area of health economic and evaluation, because we need instruments that will accurately capture improvement in people's lives if an intervention has in fact led to an improvement in people's lives. There's an expectation that we will be confirming the domain structure of any measure. There's also now an expectation that we incorporate more modern psychometric analysis approaches. So we need evidence around whether or not every question or item within an instrument captures the domain that it's trying to measure appropriately. And we would use things like item response theory or rationalysis, something like that, to demonstrate the performance of each question within an instrument, and really also think carefully around whether or not every question has good measurement properties and demonstrates measurement invariance to key aspects like age and gender and ethnicity. So we also need evidence that our measures work in translation, and we have kind of fairly extensive protocols around how they are tested across different translation and whether they work. And of course, in our project, we were translating into simplified Chinese and Argentinian Spanish and German. But since then, we have tested the instrument across, I think, about 11 languages now, additional languages. And so, we need a kind of core version that can be translated such that the meaning holds, the underlying meaning holds, not the superficial direct translation, but we have a way of translating such that the underlying meaning is the same in different translated versions. And there are kind of published accepted standards that most outcomes researchers will adhere to. There are others, but the COSMIN guidance for how we develop and test instruments in the space of healthcare is kind of probably the leading guidance. So in addition to high expectations around the quantitative side, we also have fairly high expectations in terms of what qualitative evidence is required. So, it's expected that we will have evidence around the face validity and the content validity of instruments. So we are looking to demonstrate that people can understand the instruments and that the instrument is kind of a complete measure of what it is we're trying to measure, and that it's perceived by our service users as being relevant to them and not missing anything important. So, and that qualitative work is really looking to build evidence that everybody's interpretation of the questions is in line with the intended meaning. And so, you know, we're not just looking for people's initial impression of a measure, we're really looking for kind of demonstrating that that intended meaning holds when people complete the questions. So, you know, we might look for examples of things like, you know, tell me what it would be like if somebody was at a particular level of a particular question in terms of their response. What does it look like to have frequently have problems with lack of control, for example? Can we get evidence that everybody's interpreting that in the same way? And we also, you know, want evidence around the details of the question. So how are they interpreting things like the recall period? In our new instrument, we set the recall period as the last 7 days because we felt that was the best time period in which to capture some of these kind of broader quality of life aspects. But what we needed is evidence that that's what people actually use and that everybody is answering, thinking about the last 7 days. In our instrument, we use a number of examples to help demonstrate what we mean by a question. But again, we need to know that every example that we put there is going to be interpreted in the same way by everybody. So in terms of the development of the instrument, obviously after we had that large list of possible domains for the content, we then have to find questions that we can ask to capture all of those aspects. So, you know, we didn't want to reinvent the wheel. We wanted to use good questions that were already out there if they were. So we used a combination of the kind of qualitative work, drawing on the patient's voice with what was already done. And we took forward 97 questions into testing at a qualitative level. And so the testing at a qualitative level is kind of one-to-one interviews with patients and social care users and carers across the 6 countries. So we interviewed adults from aged 18 up to 95 face-to-face. And I interviewed quite a lot of the 95 plus respondents. And, you know, it led to some quite interesting changes. So one of the interesting examples that I had was working in a residential care home and talking to somebody who, I think she was about 91. And we had a question that said, do you have a problem with your hearing? And her answer was, no, I understand that question and I have no problem with my hearing. You know, she was completely happy with it. And I said, well, that's a bit strange because I feel like you're not hearing me very well today. And to which her answer was, well, I'm not wearing my hearing aids today. But if I was wearing my hearing aids, I would have been able to hear you perfectly. So then I said, well, how often do you wear your hearing aids? To which the answer was never, because they're really uncomfortable and I don't like them. So in fact, that her lived experience was not being able to hear, and our question was not picking that up. So we had to go back a little bit to the drawing board and find another way of framing the question such that we were able to capture what her actual lived experience was, which was struggling with hearing. So after that stage of the qualitative testing across the 6 countries, we kind of dropped some of the items that weren't working. And unfortunately, some of the items we've dropped might be ones that you in this room kind of rather liked the look of. So we were really struggled to find a good way of asking questions around dignity and respect. People just interpret them in ways in which we hadn't expected. They were answering them based on whether they felt they behaved in ways that were dignified and respectful, rather than what we wanted, which was really, do your carers treat you with respect? So it's not that we don't think these things are important. It's just that some of them we couldn't find a good way of asking the question. So good relationships, we couldn't find a good way of asking the question. But we also know that it correlates very highly with feeling supported and sense of loneliness. So some of those things in the red squares that were dropped at this stage were dropped because we felt they were actually being picked up in other domains. And in other areas, we have to accept that they are not well picked up, like dignity, but that it's extremely difficult to, with a single question in self-report, to find a way of asking a question in a consistent manner. So from that stage of dropping some of that content, we then went to the quantitative psychometric assessment, which, as I've mentioned, there are some fairly exacting standards in the kind of health outcomes research, and we really just followed best practice in terms of conducting both kind of classical and modern psychometric testing, and really looking for evidence that all the questions that we wanted to ask performed well. And generally, we were really pleased that they did. We had a little bit less evidence in terms of how well our questions were working in terms of picking up impact on carers. And we had a little bit less evidence that it was working in exactly the same way in China. But they were just really things that we flagged for need for further evidence. In terms of the final selection of what went into the instrument, that relied on a couple of rounds of consultation with stakeholders rather than the views of the research team. So in terms of the measure as it stands now, there are two versions of it. One is a long version with 25 items, and one is a shorter version with 9 items. And the 9 item looks a little bit like this. It's still considered to be an experimental measure by the Euroqual group, who own the IP for the instrument. Now, what that means is that we're kind of reserving the right to make changes to it. And because of the intention of this instrument to be used internationally across multiple languages, there's a need for a lot of testing with a lot of different groups. And so we've had a period of a few years now where we've built up a lot of evidence of where things are working with this measure and maybe where we can make some tweaks to make things work a little bit better. And so until we've fully explored whether or not we need to make any changes, it will remain as an experimental measure, which means it's really only available for use in research. However, we are hoping that by next year, we'll have a version that will be kind of a little bit more permanent. And we've been really fortunate in being able to have both the financial support from the Euroqual group and interest in researchers to build this evidence, because quite often in instrument development, the initial research team develops an instrument and publishes it, and then it's quite hard to make changes. Even if we get an accumulation of evidence that particular questions are not working, it's quite, there's a lot of sort of stickiness in actually adapting to that evidence. So we've had this period of a few years where we have been able to collect evidence, and now we are able to respond to that evidence and make some changes. Now, some of those changes are in order to make the instrument a little bit more globally relevant. So the content of the kind of smaller measure, it looks quite health focused, but there are some things that I think maybe overlap a little bit more into the well-being space. So, we included loneliness and aspects of autonomy through control. And it's a broader measure than some of the other health outcome measures. So if anyone is interested in having a look at this further, then there's information on the Euroqual website. Okay, so my fifth thing that we do well as health economists is we work to get our outcome measures to a single index. And when we do economic evaluations in healthcare, we know that we will need to compare improvements on different aspects of quality of life. So, for example, we will need to know, how do we compare reducing pain from severe pain to mild pain? How can we compare that to improving anxiety from having moderate anxiety to having no anxiety? So we need to compare at the domain level, but also across the different levels of each of the domains. We also know that we will need to compare improvements in quality of life with additional years of life. So, for example, if we wanted to assess the cost effectiveness of semaglutide for type 2 diabetes, we know that some of the outcome will be reducing the probability of non-fatal strokes, and some of the outcome will be reducing the probability of fatal strokes. So we have to have outcome measures that can handle those within domain comparisons and the quality of life versus length of life comparisons. And that's where our quality adjusted life year comes in. And it's just a pragmatic means of allowing us to make those comparisons. So just for anyone in the room who isn't familiar with the quality adjusted life year, the way that we calculate them is by having each state, each quality of life or health rated quality of life state valued on a scale in which 1 is full health and 0 is anchored as equivalent to dead. And you can go below 0 if you have states that are considered worse than dead. Now, that value is often referred to as a utility value, but many health economists are a little bit uncomfortable with that because we don't really operate in a welfare economics kind of world. We have a kind of get out free card where we can say, but we are in a non-welfare economics world. We are extra welfareists. This doesn't mean utility in terms of individual utility in the way in which we would think about it in economics. It simply means overall, what is the kind of social value of living in that state? Typically, it's assessed by members of the public. So we could say, if we're thinking about the state, which I haven't described, but it's a mild health state with some problems, and we could say, well, the public thinks that to live like that has a value of about 0.7. So it's kind of just a social assessment of value of that state. The term utility is a little bit unhelpful maybe in this space, but we're kind of stuck with it. So when we're thinking about quality adjusted life years, we are thinking about how many years people spend in a state. So if we just look at this, the red bit here, we have 4 years spent in a health state that's judged to be of a social value of 1, so that's 4 qualies. We then have 5 years spent in a health state at 0.5. Okay? So that's 3.5 qualies. Now, this is really useful for us for considering what the additional quality gain is from treatment. So in this example, that little blue box is the 5 years that a patient gets in addition to their life because of their treatment, but it's spent at a fairly poor quality of life. So it's judged here at a utility value of 0.3. Okay, so we can look at the profile of somebody's life weighted by their quality of life, and then we can look at what the additional quality gain is we get through interventions. Now, obviously, it's not easy to get that utility value that idea of, well, what does the public think it would be like to live in this health state? That's not easy to do. And I think there are very few health economists who would happily say, we do this well. It has a lot of assumptions behind it. Not all of them are supported by the evidence. We do it roughly, and it kind of works. That's about as far as I'd go in terms of supporting it. So we use a lot of different methods. One of the most common methods is time trade-off. And in a time trade-off exercise, what we would do is we would ask the public to think about living in a particular health state. I apologize, the writing's a bit small here, but on the blue, the box at the bottom, it describes a health state. And that health state is moderate problems walking about, severe problems washing and dressing, slight problems with performing usual activities, severe pain or discomfort, and severely anxious or depressed. And we say to the members of the public, can you think about what it would be like to live like that? Imagine hypothetically you had to live your life like that. And then we say, would you prefer to live in that state for 10 years or in full health for 10 years? Now, at this point, almost everybody will say, I'd prefer to live in the full health. So then we say, okay, what about if that full health period, that green bar at the top, was reduced to only 5 years? At that point, which would you prefer? 5 years in good health or 10 years spent in this poor health state? And depending on their response there, we will iterate to a point in which they're indifferent between the two lives. And we use that as a measure of their utility or value for that health state. There are other methods. So we might use a simple kind of discrete choice experiment approach where we simply say, do you want to live in life A or life B? Now here we're not anchoring this to any a duration of time. So there would need to be some additional step in the valuation to anchor it to a time period. But these kind of choice questions are sometimes easier for respondents to understand. And there are variations that we do around this kind of choice experiment to try and get at the social value of those health states. So we do have multiple methods, and we are still working as health economists to improve these methods. This space is still quite dynamic in terms of finding better ways to elicit preferences. And some of what I mentioned before around working with the public can really help us ensure that the results that we get from these kind of exercises are kind of valid and meaningful. Nothing is perfect, but they kind of work and they're very useful because they do give us the public's judgment on what's important, and then they allow us to take our complex multi-item instruments into a single score. And of course, with the QALY approach, we can think about modifications to it. So we're not stuck with just the single answer from our cost effectiveness models based in terms of incremental cost per QALY gain. We can do other things. And in the US, they're particularly interested in the equivalent value of life years gained, which is a way of saying if we have additional life of somebody that has what we would judge as a poorer quality of life, in our QALY model, if someone has a poorer quality of life, then that additional year is going to be less than 1. Now, that's particularly problematic if we have people with chronic health conditions or disabilities, because we would be giving less weight to their additional time. The QALY model has been criticized in the past for being ableist because of that. However, we don't need to use it in that way. We can still use the QALY model as a way of valuing improvements in quality of life. And we could simply, as this equivalent value of a life year gained approach does, say any additional time can simply be valued as full health in our economic models. So we can make changes and adapt the model to what the decision makers want and take account of issues such as the possibility of being criticized for being ableist. So the other thing that's worth noting is that our economic evaluation results and evidence is never the only part of any decision making. It's simply there to provide useful evidence for the decision makers. And they might either kind of formally through some kind of multi-criteria decision analysis approach, give it a particular weight, or they might informally incorporate it into some kind of deliberative decision-making process. So we never expect it to dictate the actual answers to decisions. Just in terms of valuation, just want to flag that the new instrument is being tested using multiple methods at the moment, but currently only one value set is actually published. So the final thing that I think we do well in health is being able to communicate uncertainty to decision makers. And in health research generally, in clinical trials and economic models, we do extensive and transparent sensitivity analysis. It's very much expected that in any kind of published economic model, probably close to a third or a half of your paper will be the sensitivity analysis, where we are kind of saying, well, okay, tell me about the uncertainty of the parameters in the model. What difference will it make if we had different assumptions or different sampling within that data? So we explicitly explore that. But we also try and find ways of communicating that in a condensed and user-friendly manner. So, we're asking questions like, well, what if we did use a different way of measuring? What if we did use something that was a little bit more like well-being compared to something that focused more exclusively on health? How does it affect the results? What if we thought about the impact of quality of life on the carers of the results? What would it look like? And what if we were to change the threshold of when we judge something to be cost effective? What then? So, health researchers use quite a lot of visual tools. And again, this is a space which is kind of developing to really help us communicate uncertainty to policymakers. So just one example of that is the use of cost effectiveness acceptability curves, which show the probability of different interventions that you are assessing being cost effective at different thresholds of willingness to pay for a quality adjusted life year. So I know I've flicked over that point quite quickly, but there's a lot to say, and I kind of just want to flag it as something that health researchers, I think, do very well. So one thing I kind of want to raise to you really is whether or not there is space for the outcomes that we use in health and social care research to be used more broadly across other sectors. Does it have a broader role? And I think in answering that, I kind of want to take a bit of a step back and say, well, what fundamentally is the role of government and government policy? And we might all disagree a little bit here, but I think we could probably all get behind the idea that our policy is designed to address market failure and collective action problems, and it's to provide a safety net for citizens and to alleviate suffering. I think we would all agree that they are core roles of government policy. And if what we're wanting to do is to kind of alleviate suffering, then actually our health measures are really quite good at being able to identify that. So our health outcomes, like the QALY, they really can quite effectively capture aspects of individual lives that are not going well. So the EQ5D, wrong instrument, the EQHWB, the new one, as I've tried to show, it does cover the real core aspects of health-rated quality of life. And it goes a little bit broader because we wanted to capture the impact on carers too. So, this is aspects that are common across most conditions, and it's tapping into really what's common across most people's lives. And if we were to really extend much beyond that, then potentially we might not have that much consensus. If we start to try and capture, do you have achievement in your life? Is your life full of purposeful and meaningful things? Do you have spirituality? Some of the things that maybe as well-being researchers we would quite like and we might think personally are important, but we are unlikely to have consensus, not just across policymakers, but across members of the public, that what they care about on a day-to-day basis is, things like fulfillment and purpose and meaning. So if we want, a life free of problems and free of suffering, it's a foundation for people to be able to live their lives in the way that is meaningful for them. And we might have different conceptions about what that looks like. But if we can alleviate suffering and provide the basics in terms of physical and mental health, then, that's okay. So it's okay to have, I think, ceiling effects in our population measures if what we're wanting to do is make sure we alleviate suffering and we act as a safety net for the citizens. So increasing years spent in good health and also equality around that as well is really a key component of measuring progress. So I guess my main kind of message that I've been saying is, if we really think that the primary role of government in the space of well-being is the alleviations of suffering, then the tools that the health economists and the outcomes researchers and the clinical trials researchers use could maybe be applied more broadly. Okay, thank you very much for listening.
Thank you so much, Tessa, for this. Oh, you see. For this, yeah. I mean, I don't need to open the floor. There is already hands raising, and we have 10 minutes. So, Chris, then Chiara. I can get a microphone over. Oh, no, I keep this here for you. Sorry. Chris. Yeah. Thanks. It was very, very inspiring. Thank you so
much. Thanks. I thought that was absolutely brilliant talk. I want to ask a question about the most challenging part for me at the end, which is the qualities, the evaluation of time. And I understood the distinction that you were making was between some kind of a societal group preference versus an individual utility. But the other way to look at it is that it's the difference between people who are guessing and people who have actually experienced something, which is the very critical difference to the subjective well-being approach. And it seems like the difference between those is sort of unbounded, right? So the projection bias of, say, what we think it would be like to have some disability when tends not to take into account what it's like to have an accommodated disability. And so if you ask people what, to value loneliness versus some physical injury, they might just really get it wrong. So I wonder whether, now I can see there's a way to argue this philosophically the other way around, in which decision-making intent happens even if people are systematically wrong. But this doesn't seem to address the really big advantage that subjective well-being has. And I mean, this gets to your really key quote. You said, what matters is not a question for philosopher kings. But how do we deal with the fact that people might be systematically wrong and that we should privilege people who have the lived experience of a condition?
Thanks, Chris. Can I answer that? Yeah?
Yeah, go ahead.
Thanks.
Yeah.
Thanks. It's an excellent question, and it's a long-standing debate, not just between the health researchers and the well-being researchers, but even within the health researchers, in the sense of, do we use the patient's preferences to value health states that they have lived experience in, or do we use members of the public? And different countries have different views in their reimbursement agencies as to which they prefer. NICE very clearly prefers members of the public, but some of the Scandinavian countries don't. So, you know, it's an unresolved issue. I think what we could maybe agree on is that we don't want very uninformed preferences. So, but whether we need people to be valuing their state as they're currently living in it, in terms of kind of experienced well-being, compared to valuing states where they are fairly well informed, I think we could argue that actually, as long as we're willing to rule out very uninformed, it's okay. That would be my approach. And I think involving members of the public in our valuation exercises to make sure they're well understood is very useful. And I think, health economists could be criticized in the past for conducting valuation exercises with people who really weren't very informed about what they were valuing at all. And I think we have some, interesting examples in the sense that often with the physical health conditions, our patients will give those higher values, but with mental health conditions, often the patients will give them lower values than members of the public. So we are, I think, still understanding this space and doing valuation exercises in a more rigorous way so that we can narrow down to using informed public preferences. I mean, and I think ultimately, NICE's argument would certainly be is it's the public's money, and therefore they do have a right to have the say in what health states they would like to see most money spent on to avoid in the future. So, I don't think we're going to kind of find a way of settling a long-term kind of disagreement, but I think there are things that can be done in the valuation space that would reduce that difference.
Thank you. Maybe for the sake of time, I suggest we collect 2 or 3 questions together. So we have Chiara, Mark, and Lucia.
So my question is very much related so my question is very much related to Chris' question.
Is this working? Okay, just get it closer.
Okay, so my question is very much related to Chris' one, and is whether there are systematic exercise to validate these measures by looking at, for example, focusing only on quality based on patients group. So asking really people that are in those situations how they evaluate the situation, or maybe also asking only clinicians. Because it seems to me strange to evaluate treatments without asking doctors. It's a little bit like discussing on measures to mitigate climate change without asking the climate scientists, perhaps. Yeah.
Thanks. I really enjoyed that talk. It was very, very thoughtful. I just wanted to pick up this idea about whether the primary role is to alleviate suffering, because I think, to my mind, the well-being state should really go quite far beyond that. And in the context of health, maybe one illustrative example, I have a friend who's getting shoulder reconstruction through the NHS at the moment, and the NHS's doctor there is very explicit that his obligation is only to get her back to kind of this sort of range of movement. She's a former professional gymnast and derives a lot of well-being from being able to do handstands and these kind of things. And it seems to me like in a very wealthy state where we're oriented towards well-being, we should be trying to help people get to health states where they can do the things that self-actualize or are personally expressive or something like that. And that seems to go beyond alleviating suffering. I wonder if you have any reactions to that.
Thank you. Very interesting talk. So I have 2 questions about the pain measure. So the first one is whether there's any reasoning behind the 7-day time frame in the question. And then the other one is whether there's also a time frame in the scenario. So you have severe pain for 1 day, 4 days, 1 month, and so on. That's it. Okay, next one.
I'll answer that one first, and then I'll just say couple of things. One around the duration being 7 days, and one around the measurement of pain. So the 7 days was maybe a little bit of a pragmatic decision initially, because, you know, looking at the evidence, we know that when people focus on just today, a lot of patients feel that there's part of their experience is not being captured well in that. So we knew from the literature that potentially today was problematic. And because we wanted to capture things like control and loneliness, it's quite hard to assess that on a single day basis. But we were reluctant to go beyond 7 days because then we felt that accurate recall is problematic. Since this work, I've recently published a review that compared the 7 days to the 1 day. And you do get different answers, which is unfortunate. We tend to get people reporting more severe problems and lower quality of life when we ask the framing around 7 days than a single day. In relation to the pain, it's kind of a good spot, and it's something that our patients and our public advisors were very keen that we didn't just focus on severity of pain, and that we incorporated some aspect of frequency as well. And in the 25-item instrument, we ask questions. We ask 2 separate questions, so we can capture both frequency and severity, both of pain and discomfort as well. So yeah, the question around suffering, maybe suffering is too an extreme word, because I think if you were to look at what's on the EQHWB, you know, we have a way of capturing, you know, fairly mild movement from, you know, sometimes feeling lonely to not feeling lonely at all, or sometimes feeling lack of control to none. So we can actually capture things that maybe are not quite, suffering is a little bit too extreme. In the example you used, I guess I would kind of say, you know, this is the public's money that we're interested here in evaluating. And so it's more a question of priorities, and that the priority should be to ensure that we bring up people out of poor states and out of suffering, and that unfortunately some of the maybe higher level that goes beyond, you know, those broad aspects that I've showed in the EQHWB, it's more those kind of higher purpose, meaning, fulfillment things where I feel like actually if the public doesn't agree that they're key to what matters to their lives, then I think we have to question whether or not we should have them in instruments that are evaluating public expenditure. And yes, picking up on this, why not the patients? I think we could argue why not the clinicians a lot more easily, because I think the clinicians have a particular perspective on the condition, and they tend to be fairly medically focused rather than the quality of the life of the patients. And so I think we could argue that it's reasonable to rely much more on the patients than the clinicians. Why public when we could ask the patients? I think it's difficult. We cannot always ask the patients. If patients could always undertake these kind of exercises, that would be easier, but ethically it's not always appropriate to do so. And of course, one interesting thing is that often as soon as somebody stops being a patient, their preferences may revert back to being more like aligned to the public preferences rather than what they might feel at the time. So we are dealing in hypotheticals, and that's, not necessarily a comfortable space. But I guess I just want to bring this back to, there's a lot in what the health researchers do that isn't about qualis. that still is kind of useful practice. The quality component and the valuation component is contentious. Not everybody within the health economics field agrees on how that should be done. And there's definitely space for us to improve and really understand kind of a little bit more why it is we see differences between the public's views and the patient's views.